to, record the lecture. Or I'll think that she's here. That's still being here. I'm gonna turn it off for a little while. All right, so this chapter is over phlebotomy, which is drawing blood. So we're about to start learning that. So page 83, quality assessment. The term quality assessment or quality assurance encompasses policies that maintain and control processes involving the patient and laboratory analysis of specimens. So quality assessment includes monitoring the following specimen collection measures. Preparation of a patient for any specimens to be collected, the collection of valid samples, proper specimen transport, performance of the requested analysis, validation of test results, that's a big one, recording and reporting the assay results, transmitting test results to the patient's medical record, and any documentation, maintenance, and availability of records describing quality assessment practices and quality control measures. So quality assurance is basically making sure that you're doing everything you're supposed to do, okay? And if for some reason you're not doing something that you're supposed to be doing, you're eventually going to figure it out that you're not doing it right, and then you have to change it, okay? So it's basically just following through that process of making sure that your results are correct, that you're reporting the quality patient results. So the accuracy of lab testing begins with the quality of the specimen received by the lab. This quality depends on how a specimen was collected, transported, and processed. So you might be thinking, well, what does that have to do with patient results? Well, you're going to learn in a minute that certain tests go in certain tubes. If a test that's supposed to go in one tube goes in another tube by accident, it could affect patient results, okay? A laboratory assay will be no better than the specimen on which it is performed. So go to where it says phlebotomy in blue and bold. Venous or arterial blood collection, which is called phlebotomy, and capillary blood collection. So capillary collection is the pricking of your finger or the pricking of a baby's heel, okay? But drawing blood from a vein or an artery is called phlebotomy. It remains an error-prone phase of the testing cycle. In the United States, it is estimated that more than 1 billion venipunctures are performed annually. Venipunctures, you puncture a vein, okay? Break some words down. And errors occurring within this process may cause serious harm to the patients, either directly or indirectly. Leading causes of pre-analytical errors. What is a pre-analytical mean? Before testing. So pre-analytical, before testing errors. The specimen collection tube is not filled properly. Patient identification error. That's one of the main ones, patient identification. Inappropriate specimen collection tube or container. And a test request error. Other types of potential pre-analytical errors include hemolyzed specimens, blood clots caused. So hemolyzed, let me go back. Hemolyzed is the rupturing of red cells, if you want to put that definition. Or hemolysis. hemolysis. It's the rupturing of red blood cells. So right here, this is called a serum separator. Tiger Talk, SSC, several different things. So whenever you spin blood down, your red cells go to the bottom. This is a separator that separates your serum from your cells, okay? And then this is your serum, the liquid part of your blood. It's supposed to be a yellowy straw colored fluid. But you see right here, it is red. That's hemolysis, okay? These red cells rupture. When red cells rupture, they release free hemoglobin, okay? And when they release hemoglobin, your serum turns red. Um, so right here, that's normal. These are normal. That's normal. These right here are normal. You can see hemolysis right here. There's different levels of hemolysis. So right here, this is normal serum. This is just slight hemolysis, and then it grades it. So this will be like a 1+ hemolysis, 2+ hemolysis, 3+ hemolysis. You cannot perform any testing on a hemolysis sample because what you're doing with these tubes is you're doing chemistry tests, okay? And it can affect chemistry results. So you probably learned in anatomy about, and probably a little bit of chemistry too. So cations and anions and how potassium and sodium is in the major intracellular and extracellular cations, I want to say. So whenever it is ruptured, then potassium, which is usually inside a red blood cell, goes out. Okay. So these cells are ruptured. So what do these samples have more in it if potassium goes out? Have more potassium. So if you run this, okay, the potassium especially is going to be abnormal because this has more potassium in it than what the person truly has in their body. Does that make sense? Okay. There's another term that we're going to learn in a minute called lipemia or lipemic. And so it has, so this is normal, your normal serum. But you see how this has like a milky substance color to it. So that milkiness is called lipemia. Like I said, we're going to talk about it in a minute. But what that is basically fat in your serum. So a lot of times, or like triglycerides, it's actually chylomicrons, but that's a big fancy word for fat. And so people with high triglycerides and high cholesterol, this is what their serum usually looks like. And because it's essentially much fat. A lot of times when people aren't fasting and have like literally just they ate a good fried meal or hamburger, a Coke, something not good, sometimes it can look a little milky. Shouldn't be this milky, but it can look a little milky. Um, See, that is a severely lipemic sample. Sometimes they can be even hemolyzed and lipemic, so kind of like this. Whenever you get to the lab, you'll probably hear strawberry milkshake, because that's what they call it. But what it is it's lipemic, but it's also hemolyzed. So it's like a pink milkiness to it. They're so this right here, so you know this is kind of normal, essentially. This is a normal serum. But you see how these are darker? Okay, this is something, it's another term. It's called icteric. We're going to talk about that in a minute too. But basically, what that is bilirubin. So something's going on with their liver. If you have like a really dark serum or a greenish hint to a serum, and when I say green, not like yeah, that has like a green tint, kind of not like that one too. It's a dark, ugly green. Okay. Some serum can be bright green, and that can be medicines and stuff like that that can affect that. But when I say icteric, I mean that dark, nasty, ugly green. But usually, like this one kind of, I like that. But we're going to talk about those in a minute. But that is hemolysis, is when the red blood cells rupture. So other types of potential pre-analytical errors include hemolyzed specimens, blood clots caused by inadequate mixing of evacuated collection tubes containing anticoagulants. So remember we kind of talked about that not too long ago, talking about that purple top tube has an anticoagulant in it. And remember, I said you have to invert it, not shake it, because what do you think you're going to do if you shake it? You're going to rupture the red cells, which is called what? Hemolysis. You're going to hemolyze it. So you can't do that. So you have to invert it. And what you're doing is mixing that anticoagulant in that blood so that it does not clot. An anticoagulant, clot, so clotting. Anti against clotting. So that's what it does. It will not allow that blood to clot. And other factors that affect the volume of blood collected in an evacuated tube. Underfilling an evacuated tube containing an anticoagulant can change the ratio of blood to anticoagulant and can interfere with accurate test results. Turn the page. The next paragraph. Because the tubing is attached to a butterfly needle, the first tube collected will underfill as a result of the tubing. So what that's saying, so this is an example of a butterfly needle. Okay. So this part right here, let me see if I can find it attached to the tube. There we go. So this right here, that's how you use a butterfly. And so this right here, when you first collect it, think of all this as having air in it. Okay. So whenever blood flows through, okay, you get the blood and it goes through into your tube right here. All that air has to go in there also. Okay. So that first tube that you fill up, it's going to be half air, half blood. So that tube can't fill all the way up. Okay. So if you use that one, you can use it, get a little bit of blood, throw it away, and then collect your tubes. or with that one, you just need to make sure that you have enough for whatever test you're gonna do. So because tubing is attached to a butterfly needle, the first tube collected will underfill as a result of the tubing. If a winged blood collection device called a butterfly is used to collect a light blue top tube for coagulation studies, then a waste tube should be drawn first. So light blue, I'm going to give y'all a chart in a little while with literally every, or maybe tomorrow, might do it tomorrow, with every tube and some of the major tests run on that tube. So a light blue top tube has to be filled 90% of the way. Okay, make sure you note that because that is important. So these are your light blue top tubes. You see this arrow right here? That's where it has to be filled to. It's 90% of the way full. So it either has an arrow, I wonder if any of these pictures show it. Right here, it would go about right here. There's that arrow. There's like a line on the back of those. You can't see it, but there's a line, and it's like a clear line going around the top, and it shows you where to fill it at. So like in this one on the back, it's just a clear line that goes around the back, and that's where you'll fill it to. And the reason why is because this has an anticoagulant in it. With that being said, this tube is used for coagulation studies, meaning you're going to run tests on this tube that checks your clotting of your blood. If you have too much anticoagulant, that can be falsely elevated. Does that make sense? Because it's not making your blood clot. You have too much of it, okay? So if you have too much anticoagulant, then your blood's going to clot more than it normally does. Does that make sense? It's going to take longer to clot. So it's important to have this filled 90% of the way full. Go to patient care partnership. So it says, 3-line sound. When collecting blood specimens, it's important that the phlebotomist considers the rights of the patient at all times. And then it talks about the different types of patients that you may have: pediatric patients, adolescent patients, adult patients, and geriatric patients. So go to pediatric patients. And it's just talking about in this paragraph, you know, be gentle and compassionate. Obviously, you're not going to go up to a pediatric patient and be like, give me your arm, you know, which you shouldn't do that to anybody anyway. But, you know, little kid's going to be scared, obviously. You're not going to be like, listen, you know, grow up here and sit in this chair and do what you're supposed to do. You're not going to sit there and do that to that baby. You're going to be like, come here, sweetheart. Let me show you that, you know, you're going to coerce them. You're going to talk to them gentle. You're going to be compassionate. And another thing is their parents are standing there. So listen, I am one that you got about one stick with my babies. Okay? You got one stick with my babies, and if you can't, and I understand, I know that people are in school and people have to learn. But my babies, they ain't pin cushions. Okay? I'll be your pin cushion all day long, but my babies ain't gonna be. You better get somebody in here that knows what they're doing. Okay? You got one chance to get it. And I don't tell them that. I'm not the type of parent that walks in and go, hey,
You got one chance, and that's your chance.
No, I just sit there and I let them do their thing. But they don't get it the first time, and plus I know, I can tell if they know what they're doing anyway. So if they in there and they look lost and they're in left field, I'm like, baby, can you please go get somebody else? Because we need to do this. Okay? But with that being said, their parents also there. That parent ain't always gonna be nice. Okay? That parent, you might have that one parent that comes in there.
You get one stick with my baby.
And plus, what does that put on you? That puts a lot of stress on you. It really does. Because you're already nervous because you're sticking a kid. But then you get nervous because the parent's sitting there like watching you over your shoulder, you know. And so you have to remember that you have both the patient, which is the baby or the kid, and then you have the parent there too. So you have to make sure that you kind of ease the anxiety with both of them. And it's saying, you know, do not hurry. You're going to allow enough time. It's important to sometimes take extra time to gain a child's confidence. If you need help in restraining, sometimes we do have to restrain kids. Listen, I don't know. I know about 2 kids that are going to sit there and hold out their arm and sit there for you. Okay, about 2. Not many are going to do that. They see a needle, they're going to get up, they're going to run, they're going to pitch a fit. I mean, sometimes you may need help in restraining. And this is also true for adolescent and adults sometimes too, which is absolutely ridiculous. But anyway, that's just my opinion. But legit, I had a 14-year-old girl one time, and if I was her mama, I swore, probably would have got feedback called on me. But you know, I used to work in a pediatric office. So she was 14 years old. I get people are scared of needles, totally get it. But when I say that there was 4 of us that had to hold this girl down just to give a shot, and the mom was pregnant, and she like about 8 months along, and she kicked her mom in the stomach. Yes, I'm telling you, it was all I could to like not snatch that kid up and be like, do you not realize what you just did? You know, whew, I'm telling you, I had to have a cup of Jesus meeting in that room that day. It was really sad. Like, it was ridiculous. But I mean, there's nothing you can do about it. She's scared of needles. And there no but how much coercing you did or how much, you know, babying, it's okay. No, she wouldn't have it. But she literally kicked her 8-month pregnant mom in the stomach, and the mom thinks a lot of problems with mama. Mama's like, oh, it's okay, it's okay. No, it ain't okay. You're gonna kick me and we're gonna see what happens. But I mean, it was crazy. But sometimes you need help. And it's okay. Ask for help because you would rather ask for help in situations like that instead of that kid going crazy and then you getting stuck. Okay, or the kid getting stuck somewhere that they don't need to be stuck, and it's just a disaster. It's talking about in the nursery, every hospital has its own rules. After working with an infant in a crib, the crib sides must be returned to pre-collection position. So if an infant is in an incubator, then the portholes should be closed. So especially that's really important about the crib sides is that sometimes you might have to go and collect babies in cribs in the hospital. And so you always want to put the crib sides back up, obviously, because the baby could roll out or the toddler could get out or whatnot. Adolescent patients, it's just talking about being relaxed and alert to possible anxiety. Some adolescents may mask their anxiety. A lot of guys try and do that. You come in there and the little 12, 13, 14-year-old, especially guys, they're like, oh, you're gonna cook. And they get in there, but they're nervous as all get out. So just kind of look for stuff like that. Allow enough time. Um, Make sure you establish eye contact with your patients and even your little baby patients. Talk to them, you know, and even though they have no idea what you're saying, you know, it just gives, remember that parent's in there. So it gives them a sense of, you know, it really does as a parent. Whenever you have somebody that comes in there that's working with your kid and they interact with your kid and they talk to your kid, it almost gives you a sense of ease that they're in there and that they're acknowledging that your kid is a patient, okay? And not just, you're not in there just to trick them and get it over, you know, that they really, it does use the mind of patients. I mean, of parents. So with adult patients, you know, honesty is important. Be greeted in a friendly and tactful manner. Be pleasant. The patient should be told about the purpose of the blood collection. And if you go down a little bit more, it says many patients in the hospital are lonely, so kindness is greatly appreciated. Occasionally, especially if extremely ill, the patient may not want to talk at all, and that should be respected. So don't go in there and be like, hey, you gonna talk to me? You know, no, we don't do that. Another thing, this actually come up at a hospital recently, I think, with an employee that I heard about. So if you think that you're going in there and they might not be able to hear you because they might be crazy. You might be working a behavioral health unit. And they might have some goodness going on, you know. You might think that they can't understand you. Or older patients who are just, you know, laying there in the bed and you're like, they can't understand a thing I say. Watch what you say in front of them. Because next thing you know, you say something and they'll look at you and repeat what you said. Or say, no, that's not the truth. Or, you know, whatever. So apparently, there was a situation where something happened where the phlebotomist said something in front of like a mental health patient, thinking like the mental health patient was not in, you know, was incapacitated and could not understand what she was saying, and she got told essentially because that mental health patient was like, no, I understand what you're saying. That's not what happened, or da 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 da. And then even so, like, you know, don't talk about patients like about their appearance or, you know, anything like that. Like, that's just totally, totally unprofessional. You're in there to do your job. You're in there to collect the blood, get out. You're not in there to gossip with your coworker who might be in there with you know, talking about the party you went to this past weekend or, you know, whatever. You're not in there to talk about anything, or your coworker. I can't believe that heifer is down there in the lab doing this, this, and this, da 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 da. No, you're not in there to gossip. You're not in there to do anything like that. You're in there to collect the blood, get it out, and send it back home. So even if the patient is disagreeable, the phlebotomist should remain pleasant. Listen, you're going to have a lot of them. You're going to have a lot of disagreeable patients. A smile can often work miracles, and that is true. In a hospital setting, before leaving the patient's room, the area should be checked to see that everything is in place in the lab tray and that the room has been left as it was found. I'm on page 85 at the top. All sharps and supplies should be disposed of properly. So geriatric patients, Even with adult patients too, it's best to address the patient more formal. So Mrs., Miss, or Mister rather than his or her first name. So you might go in, a 10-year-old's room and say, hey Joshua, I mean, obviously you're probably not gonna say, hey Mr. Harris, how are you? Just him. So you might say, hey Joshua, how are you doing today? But in a 50-year-old's room, you're gonna say, hey Mr. Harris, how are you doing? You're gonna address them appropriately. Instead of walking in and be like, hey Jake, how's it going today? No, you're gonna address them a little bit more formally. As with patients in general, older patients may enjoy a short conversation. Keep a flexible agenda so enough time is allowed. If a patient appears to be having difficulty hearing, speak slightly slower and louder. Sometimes a lot of our older patients have difficulty hearing, so you might have to talk louder and a little bit slower so they understand you. Okay, you might have to. It seems ridiculous, but you might have to so they'll understand you. But then also don't talk to them like they're dumb either. Okay, like they act like they can understand you, then, but just because they're old, don't talk to them like this because they're old. Okay, you can feel them out before. You'll know if you need to be slower and louder with them. So some phlebotomy challenges. A phlebotomist must never proceed with a procedure until any obstacles have been remediated. Difficulties can include simply finding a patient or identifying a patient under difficult circumstances. Patients themselves can present challenges. So a sleeping or unconscious patient. If they're unconscious, there ain't nothing you can do about it. Get in there, get your blood, get out. Okay. What you gonna do? Try and wake them up? No, they're unconscious. Sometimes if they're sleeping, you want to be quiet. You might not want to wake them. Sometimes they'll wake up. Sometimes you can go in there and wake them up. Just like touch them on the arm or something. Like, here's your blood. Just like don't go in there. I was in the hospital for something. I've been my history. Anyway, I was in the hospital and this one girl coming there to draw my blood. I mean, it was in the middle of the night. I was sleeping. And instead of coming in, being quiet and, it's in the middle of the night, she come in, turned all the lights on, cleaning stuff, and I was like, excuse you? Like, it's just common courtesy. Like, just go in there. You're gonna need some light. Turn light on, but don't go in there slamming trays and this, that, and the other. Just be gentle. That's all you gotta do. Apprehensive patients who have language barriers. So, that can be a difficult issue. A lot of times, what you'll need is an interpreter. And especially more so around here, it's your Hispanic patients. And I don't know what the policy is anymore at Meadows, but they used to have a little interpreter line that you could call, or if there was somebody there that could speak Spanish, they could interpret for you. But I want to say, unless they were hired to do that, then there was some legality issues about that, because how do you know that they're interpreting technically what they're supposed to interpret type thing? So, but I don't know what policy is now since HCA took over. Combative patients. Hey, there's going to be combative patients, especially these older patients. A lot of the patients might have Alzheimer's, so they don't understand what you're doing. So they have something called sundowners. And what sundowners is when the sun goes down, they turn into the devil. It's bad. And then when the sun, literally, and the sun comes up, And it's like, they're the most pleasant patients on earth. I literally had this happen to me, one time, and it actually was not when I was the phlebotomist, I was a ward clerk, immediate secretary. And, it was while I was in school though. And, it was an older patient, she had sundowners, and so the phlebotomist was in there trying to get her blood, and she was in there scratching and kicking and hitting and spitting and all this mess. So, of course, you have to have help. And so I'm in there trying to help her. And you can be stern with these patients, not be like straight up a butthole to them, but you can be stern with them. So, like that lady was sitting there, she scratched me, and so I grabbed her hand, and I held her hand down. It's not like I was like, but I did. I grabbed her hand firmly and I held her hand down so she could not scratch me. And she looked at me and went, spit on me. And I said, no, ma'am. I said, well, you're not going to spit. Like, you almost have to talk to them like toddlers. And so she just looked at me like, I knew she was cussing me, even though she wasn't speaking. And then, so got her blood, left and went out. She actually had to end up being put in restraints that night because she was bad. The next morning, go in there, and I'm like, good morning, whatever her name was, Miss So-and-so. Because what I would do, even though I was a ward clerk, I still had a lot to do with patient care because, especially if we were full, I didn't have anything to do. So they would kind of pull me to do CNA work almost. And so I went in there and I was like, good morning, Miss So-and-so. She's like, good morning, sweetheart. How are you doing? And I was like, and just last night you spit on it, I mean, but legitimately, it's a thing. Like at night, when the sun goes down, they turn into, and then the next day they're like little angels. So sometimes you're gonna have combative patients. A lot of times, especially in the ER, people that are drunk or on drugs come in really combative. So you'll see that and you're never gonna put yourself in harm's way, so to speak, but you are gonna have to deal with patients who are combative at the same time. So you always wanna have somebody in there. Infection control. So the chain of infection requires a continuous link of three primary factors: the reservoir, which is an infected symptomatic or asymptomatic host; the means of transmission, which is a contaminated object, food, or water; and then a susceptible host, which is a patient, a healthcare worker, or a visitor. So you have the reservoir, which is the person that is infected. So let's just say COVID, okay? Or I'm sorry, Allison, I'm going to use you. But let's just say that Allison was here today, okay? She would be the reservoir because she's sick, right? She's the host and she's the one that's sick and got the sickness, okay? The means of transmission would be she sneezed on her desk, and I come by and touched her desk, and then touched my mouth, and it went to me. And then the susceptible host would be me because then I would get sick. Okay. So isolation of a safety system. Isolation was once understood as the separation of a seriously ill patient to stop the spread of infection to others or to protect the patient from irritating factors. The term isolation has changed from meaning a special set of precautions performed by a few healthcare providers or a select few patients to a safety system that is practiced by everyone in the course of routine patient care. Isolation precautions are now a routine part of everyday work process. So let's talk about these isolation precautions. What is standard precautions? That's right. So the first tier, put a star by this. So it's the second paragraph. The first tier of infection control is the practice of standard precautions. So first tier, meaning if you follow standard precautions or universal precautions, called both things. If you follow those and treat all blood and body fluids like they're infectious, then you're preventing yourself from getting a disease. Okay. The standard precautions theory recognizes the need to reduce the risk for microbial transmission, including human immunodeficiency virus, which is HIV, from both identified and unidentified sources of infection. These precautions require that protective protocols be followed whenever contact is made with blood and body fluids. Well, then, transmission-based precautions can be divided into three different categories. So contact, airborne, and droplet. So contact precautions are designed to stop the spread of microorganisms through direct contact, such as skin-to-skin contact, and even indirect contact, which is usually the result of a person making contact with a contaminated inanimate object. So like me not being gloved and touching a desk that was just sneezed on, okay? Even though the person sneezed on it, I got it because I touched it, okay? I touched it and then put it up to my mouth or whatever. That's contact. If the person had directly sneezed on me, then it would be one of these other ones that we're going to talk about in a second. So a lot of times you'll learn in micro the MRSA. Has anybody ever heard of MRSA or MRSA? Methicillin-resistant Staphylococcus aureus. So that lives in your nerves, actually. Okay, so it's in your nose with a lot of people. So especially older people, you'll notice. So whenever you get admitted into the hospital, they ask you a question. Have you ever been told that you have MRSA or blah, 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 blah? So if they say yes, then what they do is put that person on contact precautions. And so they'll put a little sign on your door that says contact precautions. They'll swab your nose to see if you have MRSA, okay? And then they'll either grow it out, depending on what your lab does. They'll either grow it out, or if you use PCR, they'll set up PCR, blah, blah, blah. Anyway, they test for MRSA in that patient. The contact precautions, what that means is before you go in that room, you have to have gloves on. They make you put a gown on, stuff like that. Meaning that, because this person might have MRSA in their nose, okay? Well, if this person has MRSA in their nose, they might go like that and then touch their water jug, okay? Their water jug that's sitting there. Well, you're in there drawing their blood, and they say, hey, can you hand me my water jug right there off my bedside table? Okay, no big deal, right? You grab the water jug, give it to them. What's on your hands now? MRSA. Then you go and go like that. Or you have, let's just say you got bit by a mosquito. Okay, you got bit by a mosquito. You went like this and scratched that bite. You just put MRSA into technically an open wound. What can happen now? Get an infection. Exactly. So, but if you're in there gowned up and already have gloves on, if you hand them their MRSA cup, that they have on there, you're not going to get it. Okay. So it's just a precaution. So once they see if that patient has MRSA or not, if they don't, they take them off precautions. If they do, they give them an antibiotic. Okay. So it's just contact precautions. It's just making sure that, or it's designed to stop the spread of direct contact or indirect contact. So then you have droplet precautions. Droplet precautions protect healthcare workers, visitors, and other patients from droplets that may be expelled during coughing, sneezing, or talking. Um, so, people, whenever people are admitted to the hospital if they have the flu, okay? Like my daughter, for example, whenever she was three, I want to say, 2 or 3. The 1 year that I didn't give her her flu shot, by the way. Because I was busy, I never took her. So anyway, that's neither here nor there. But she developed the flu, and oh, she was really, really sick, like to the point where whenever I took her to the doctor that day, she was so sick and her breathing was so off that they sent us by ambulance to the hospital. She got admitted. Because usually for the flu, you know, they send you home, tell you to recover. It takes about a week, you get better. She was sick. So they admitted her and they put on her door, because she had the flu, droplet precautions. Couldn't have any visitors except me and her dad. So couldn't have any visitors. I take that back. At the time, they did allow visitors, but the doctor was, you know, like, really, you don't need to have visitors. It's the flu, you know. But of course, you know, that was grandbaby. You can tell me I can't come up there. My grandbaby. And I'm like, yes, I can, because you're not going to get the flu, because I need you to keep said grandbaby so I can go back to work. But anyway, so, but they put her on droplet precautions. And so what that means is they put a big sign on her door, you know, that said droplet precautions. And you basically, before you had to go in there, you had to put on gloves, you had to put on the gown, and you had to put on a mask. Okay, N95 mask. Because that's flu, you know. So COVID, when people had COVID, they were on droplet precautions. When people have Bordetella pertussis, what's that? Whooping cough. If people have whooping cough, they put them on droplet precautions, because when they cough, those droplets can expel and you can breathe them in. When they sneeze, they can expel and you can breathe them in. Even talking. Somebody can be talking to you and spit a little bit, okay? It lands on your face, your mouth, your nose, whatever, and that's how you get it. So, like I said, they're particularly important when dealing with influenza and stuff like that. Airborne precautions. Airborne precautions are designed to provide protection from airborne bacteria. So there's a difference between droplet and airborne, okay? Even though they're both essentially in the air at some point in time. So droplets mean sneeze, coughing, talking, and landing on you. Airborne literally lives in the air, okay? So when you walk in to a room, and if it's airborne, you're exposed to it. They don't have to cough on you. They don't have to talk to you. They don't have to sneeze on you. It's in the air. One of those is TB, tuberculosis. So, which may be suspended in the air for an extended period. Turn the page. Respiratory protection, such as N95 respirators, and the use of special air handling systems to control airborne bacteria. Airborne precautions must be observed when patients have the measles or tuberculosis. They have to wear a mask also, so kind of like with COVID too. They got to wear a mask, and then you have to wear a N95 mask. So specimen collection. Blood is the type of specimen most frequently analyzed in the lab. Put a star by that. Urine specimens, body fluids, and stool specimens are also frequently analyzed. Other specimens, such as throat cultures and swabs from wounds, are sent to micro. Knowledge of proper collection, preservation, and processing of specimens is essential. A properly collected blood specimen is crucial to quality performance in the lab. The last paragraph, strict adherence to the rules of specimen collections is critical to the accuracy of any test. The major potential sources of error include identification errors, both of the patient and the specimen. So, remember the other day I was telling y'all, I think I told y'all, maybe not, I can't remember, that at Fairview, one of my clinical students called me and they had a specimen that they thought was urine, but then it looked like it was so thick, it looked like sputum, so they couldn't tell. So obviously, urine and sputum are two separate body fluids, okay? One comes, obviously, one is pee, and the other one you have to and hawk up, okay? It's not spit. Spit is not sputum. So sputum is you get it from your lungs, really hawk it up, okay? Anyway, even worse. But with that being said, sputum is very thick, and this and urine. I mean, y'all pee here today. Urine ain't thick, right? Urine's supposed to be flowy. Well, this urine was so thick that they thought, and it really is the same color. Okay, it sputum is like a yellowy color. Think of when y'all are sick and y'all hack up stuff. It's yellow. Usually it can be green, but usually yellow. So it looked the same except the fact that it was thick. So they thought it was a sputum, but it was actually a urine. So with that being said, if they did not, understand what that specimen was, they could have easily said there were no epithelial cells present, stuff that you look for in sputum that's not in urine, they would be looking for stuff like that because according to the specimen you're looking at, you're looking for certain things. So like for urine, you're looking for red blood cells. You're looking for white cells. You are looking for epithelial cells, but you're looking for trig, which is the parasite. You're looking for several different things that aren't found in sputum. So like, there's something called casts in urine. They're not in serum. So this person may have had a lot of casts, and they're like, what are these? Because these look like casts, but they were saying, no, it was a sputum, and so that shouldn't have been in there. So what it's saying is a properly collected specimen is crucial to quality performance. And then a major source of error includes both the identification of the patient and the specimen. So you have to make sure that what you're looking at is truly what it is, okay? So the phlebotomist. Second paragraph, the phlebotomist is a critically important member of the lab team. Actually, probably one of the most important members of the lab team, I feel like. Because without a phlebotomist, who's getting your specimens? Nobody. I mean, yeah, sometimes as a tech, you might, especially if you work in a smaller hospital, you're going to get called out to come draw some. That phlebotomist, like, for example, in Swainsboro, when I worked in Swainsboro, on the weekends, you have one phlebotomist, one tech, okay? Well, let's just say that you had a trauma come in the ER, that phlebotomist is in there in the ER with that trauma, okay? And then let's just say that the person in the ICU coded. and you have, I would then have to go out and go to ICU, all while trying to work up blood bank and everything else at the same time. So that's always fun. But situations like that can present itself. In Sylvania, I worked there PRN for a little while, and on the weekends, you're the phlebotomist and the tech because they have 4 ER rooms. Yes. 4 ER rooms. So it's a really tiny hospital, obviously. And when it's my first day there, they were like showing me around everywhere. And they're like, this is the ER. And I walked in and I was like, oh, we have 4 rooms. Wow. Because I just did not expect that. And then like their beds, so they have an ICU, they have like a med surge. But it's so small, so small. So you're the phlebotomist and you're the tech. So every time an order comes off, you're gonna go, you're gonna draw the patient, you're gonna come back, and you're gonna run it and do it. So it just totally depends. Now in Meadows, obviously they have several different techs on at one time, and they have several different phlebotomists on at one time. But sometimes still, you have to go out and you have to draw. And that's one of the things about down here in a rural area is that you're gonna be required to do that. Versus like Atlanta, you're never gonna draw blood in Atlanta. Like if you're a tech, you're a tech, and that's what you're gonna do. But here, you're gonna have to go out and draw blood. So that's why phlebotomy is a big portion of, especially our program. Because I know at one time, so we have something called an IFCC committee between all the technical colleges and in Georgia. And so every program director is on this committee. So a lot of the ones from up north, like Atlanta and all them, they were like, yeah, we should get rid of phlebotomy. Like, we don't need phlebotomy, like in our program. So like, we don't need phlebotomy, blah, 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 blah. We'll just go over the basics of phlebotomy, but we don't need to teach it. And Cindy was here at the time, and Miss Cindy was like, yeah, no, that ain't gonna work down here. She's like, but I'll talk to my lab directors and see what they think. Every single lab director around here was like, no. I'm not gonna hire your techs if they don't know how to speak. And so then she went back to that committee and was like, yeah, that's not gonna work out here because we don't have, 50 million people in the lab to do a certain thing. Sometimes our techs are gonna have to go out there, they're gonna have to draw, they need to know this stuff. And so it's still a part of our curriculum. And we go over it in a very short amount of time in here because we have so much more to learn. So versus like when you went through Aaron's class, you have 2 semesters to focus on it. And here we have like 2 weeks, 3 weeks, to really focus on it. So you got to learn it kind of fast. But it is, the phlebotomist is a critically important member of the lab team. The phlebotomist represents the lab to patients. And let's be honest, my aunt, bear in mind, she actually works with the Technical College System of Georgia, and she is, she does something at the Technical College in Dublin. And we had so I told y'all we had all those meetings on Thursday. Well, Thursday night, we had the annual foundation dinner thing. And so her husband actually works here. And so she come as his guest, and she saw me and she said, we're really thinking about getting your program in Dublin. I was like, oh, really? And she said, yeah. She said, quite a bit of people, she said, that's one of the main things that they inquire about is the lab. And I was like, oh, wow. I was like, well, you never hear that, because my mind is thinking MLT, right? Mm-hmm. And she's like, yeah, and she said, so we're really thinking about getting everything to start, on phlebotomy, and oh, I was like, you're talking about phlebotomy, it's like, I was thinking, like, NLP. And I was like, oh, so you're talking about just drawing blood. She's like, well, yeah. I was like, okay, well, that's not just the lab. Like, but that's what people think of when you hear somebody say lab tech, they think of a phlebotomist. And the reason they do is because the phlebotomist is the face of the lab. That's who sees the patients the majority of the time. Because in it, even, I mean, a lot of people I know still have no idea what I do for a living. Now they know I teach. But other than that, like, they had no idea what my job contained. You know, they didn't know that I have, I can look up under a microscope and I can tell if a person has cancer or not. They just think I draw blood. They don't know that I have to cross match blood and all these antigens and antibodies and everything that's in your system, and they don't know because they don't see us. They see the phlebotomist. And so when somebody said the lab's going to come in here and get your blood, that's who they think of, is the lab, is the phlebotomist. The role of the phlebotomist has never been more important to the patient and to the lab. Critical thinking skills are also essential for phlebotomists, and they must make effective decisions and solve problems, frequently under conditions of stress. So, like I told y'all before, in a code, it is very stressful. Because you have the patient that's sitting there dying, okay, or even a trauma code, whatever. You have the patient that's dying pretty much in front of you. You got 15 nurses in there. You got the doctor in there. You got respiratory therapy in there. You got everybody in there, hands on this patient while trying to get blood, and it is very stressful. The patient's dying right there. And sometimes, especially when you're new at it, you freeze. You're like, oh my gosh, what do I do? Because you have all these people in there, you have a person dying. And then this actually happened not too long ago to somebody I know that it was their first trauma. And so they went in there, and you also you have to think outside the box. You can't get in the way of the doctor. You can't get in the way of these nurses. You can't, because they're having to be hands on, but at the same time, you got to get your blood. Okay. And so she goes in there and she's like seeing this big picture, and she froze. Like, oh my gosh, what do I do? Because you're in there and you got all this going on. And it might be a gunshot hit them. Or you go in there and you see a kid laying there. And you're like, and you freeze. And so sometimes they have to make decisions, and think critically. The majority of lab errors, though, are caused by mistakes before testing or pre-analytical errors. So that is the very last paragraph in under specimen collection, like that first, or not the last paragraph, next to the last, where it says one specific area of improvement. Y'all see that? And so the next sentence, the majority of lab errors are caused by mistakes before testing or pre-analytical errors. Put a star by that. That's important. So you have different blood collection variables. So many clinical lab determinations are done on blood, plasma, or serum. Blood specimens may be drawn from fasting or non-fasting patients. The fasting state is defined as having no food or liquid other than water for 8 to 12 hours before collection. Make sure you know that. 8 to 12 hours before collection. And it says no food or liquid other than water. You can also, the patient can have black coffee because there's nothing that won't harm. So water and black coffee when fasting. Not coffee with cream, not coffee with sugar, black coffee. Fasting. Ugh. Some people like black coffee. Ugh. The next paragraph, blood collected directly after a meal is postprandial specimen. Who's sorry about that or know that definition? Blood collected after a meal is called postprandial. In the case of blood glucose, a sample may be collected 2 hours postprandially. After 2 hours, underline this, put a star by it. After 2 hours, blood glucose levels should return to almost fasting levels in patients who are not diabetic. So in other words, what that's saying is if you collected a blood sugar and that blood sugar was 80, okay, and they were fasting, so it was 80. Then they ate, okay, so let's just say that was 8 o'clock, okay. At 10 o'clock, it should be back to around 80, okay. So after 2 hours, it should return back to as they were almost fasting. Blood should not be collected while IV solutions are being administered, if possible. Food intake, medication, activity, and time of day can also influence lab results for blood specimens. It is critically important to control pre-analytical variables such as timed drawing of specimens, peak and trough drug levels, and post-medication conditions. So we're going to talk about peak and trough drug levels whenever we get to chemistry. But when I say peak and trough, so peak, that is drawn about an hour after administering a medication, and your trough is drawn 1 hour before having to administer it. So peak is drawn 1 hour after administering a medication, and your trough is drawn 1 hour before. So let's just say that you have vancomycin, for antibiotic, and it is administered Q 12 hours, which means every 12 hours. So it's administered at 8 o'clock a.m. and then would be administered what other time? 8 p.m. So you get this medication every 12 hours. When would you draw the peak? 9 a.m. would be your peak because it's drawn 1 hour after getting the medication. And when would be your trough? 7 o'clock p.m. would be your trough because it's drawn 1 hour before the next dose. This, we're going to talk about it when we get to chemistry. It is super important because these drug levels, so the reason you have to monitor certain drug levels is because if you give too much of the drug, it could kill somebody. And if you give too less of the drug, that means it ain't working. So, like I said, this one we come up with, we just said it was vancomycin. Vancomycin is a super high-powered antibiotic. So obviously, if you don't have enough of the antibiotic, that means it's not working. If you give too much, it can shut down your liver and everything else. So, kill a patient. So these levels are important because let's just say that at the trough, your trough levels are supposed to be, let's just say your reference range is 7 to 10 for your trough. But when you run the trough, you drew it at 7 p.m. and you got 20. That's the result. Is this nurse going to give this dose at 8 p.m.? No, why? They already got too much, right? So they already have too much in there. If this nurse gives that medicine at 8 p.m., they're probably going to double or triple this, which could end up hurting them. So you see how these are important to know. So blood collection procedures. There's usually two sources for blood collection: venous blood from a vein, and then peripheral or capillary blood. Capillary blood is your finger sticks or your heel sticks on babies. Sometimes arterial blood may be needed for blood gas analysis, but I'll go ahead and tell you most labs around here for blood gases and arterial sticks, that's respiratory. We used to do that, but now respiratory has kind of gotten into the swing of doing blood gas analysis, and I'm glad. But that is from an artery. Most of the time, you will not stick in artery, okay? Unless you're me. I can't get it on one artery. But you are not supposed to. Layers of normal anticoagulated blood. In vivo, you need to know what this means. It means in the body. So in vivo is in the body, and in vitro means outside of the body. You need to know those two definitions. So it's saying in vivo, the blood is in liquid form. But in vitro, when it's exposed to oxygen, it will clot within a few minutes. Next paragraph. Whole blood that is allowed to clot normally produces a pale yellow fluid called serum that separates from the clot and appears in the upper portion of the tube. So that's like earlier, we saw the blood cells at the bottom and the serum on the top, okay? During this process of coagulation, certain factors present in the original blood sample are depleted and used up. Fibrinogen is one important substance found in circulating blood that is necessary for coagulation to occur. Fibrinogen is converted to fibrin when clotting occurs, and the fibrin lends structure to the clot in the form of fine threads in which the red cells and the white cells are embedded. To assist in obtaining serum, collection tubes with a separator gel are used. Serum is used extensively for chemical, serologic, and other laboratory testing, and can be obtained from the tube of clotted blood by centrifuge. When fresh blood is mixed with a substance that prevents the blood clotting, called an anticoagulant. The blood is then separated into plasma, a straw-colored fluid, and then the cellular components, your erythrocytes, your leukocytes, and your platelets. So, the difference in serum and plasma. No anticoagulant is in the tube when you have serum, okay? So, it yields, so serum and plasma. So, if you look at figure 4.1, okay? You see up at the top, it says plasma. And then you have like this little layer in the middle. Y'all see that? And then you have the bottom layer, which is your red cells. So that layer at the top, it is plasma if you use an anticoagulant. If you do not use an anticoagulant and it clots on its own, it's serum. Does that make sense? So in your blood tubes that you draw, you're either going to have an anticoagulant or not. Okay? If the tube contains an anticoagulant, when you spin the blood down, this portion at the top will be called plasma if it contains an anticoagulant. If it does not contain an anticoagulant in the tube, when you spin the blood down and have the liquid portion at the top, it is called serum. Does that make sense? So if you use an anticoagulant, it's plasma. If you do not use an anticoagulant, it is serum. So it's saying when you use an anticoagulant, it's separated and it's called plasma. You have the top layer, which is the plasma. You have that middle layer, which is your leukocytes. What are leukocytes? White blood cells. And what are thrombocytes? Platelets. So your white cells and your platelets. They create a little layer in the middle. That's called the Buffy coat. You need to know that. And then your erythrocytes, or your red cells, are at the bottom. Show y'all a picture. Okay, this is kind of a one. So this right here is a lavender top tube. So it does contain an anticoagulant. So if you look really closely, so right here is your plasma. You see that little layer right here? That is your white cells and your platelets. That's your Bovie code. Okay, and then here's your red cells. Same with this one, kind of, you see how, so your red cells are at the bottom, your plasma's at the top, but you see this like thin layer right here? That would be your Bovie code. Versus this right here. This has that serum separator in it. So this down here is blood, and this has no anticoagulant in it. So it clotted on its own. So this right here is what? Serum. Yep. Okay. So they look the same, kind of are the same, except when you do not use an anticoagulant, you yield serum. And then when you do use an anticoagulant, it is plasma, all plasma. We'll stop right there today and pick up on that tomorrow.